Well, welcome everybody to the IGN Seminar. It's wonderful to have Martin Mwangi and Filomena Gomes with us. They're both from the Healthy Mothers, Healthy Baby initiative of the Micronutrient Forum. And they have kindly agreed to give us a presentation that's focusing on policy and programs, like taking the scientific evidence and how to now implement it in country. And their experience over the past few years working with the Micronutrient Forum is going to be, I think, very relevant for our group. So I won't take much more of your time. Please go ahead and welcome.
Thank you very much, Sonia. Please confirm you can hear us okay?
We can hear you very well.
Wonderful. Perfect. Thank you so much. Thank you also for giving us the opportunity to speak to you today. I know it's a busy day. For us, it's probably the end of the day. It's our last presentation of the day for me. And so we are honored to be given the opportunity to talk to you about how we take the evidence that you generate from institutions such as yours and then see how that is taken to country action. So our talk today is going to focus on how we build those bridges between science, policy, programs, and we are going to intensely focus on maternal nutrition and health. But before we do that, it's a good idea to introduce ourselves. I will introduce myself and then give Filomena perhaps Filomena should introduce yourself, then I introduce myself, because the way we have planned this is that I will handle some of the slides and Filomena will handle others, and then I will come back to conclude. So over to you, Filomena.
Thank you so much, Martin. It is a real pleasure to be here today. My name is Filomena. I am a Portuguese nutritionist and dietitian by background. I am working as a senior program manager at the Healthy Mothers, Healthy Babies program of the Micronutrient Forum, and I am also an affiliated professor at Nova Medical School in Lisbon, or in the capital of Portugal, where I am currently sitting on. Martin, over to you.
Thank you, Filomena. And I am a nutrition epidemiologist, originally from Kenya, living in the Netherlands, where I'm based. Perhaps some of you have been to Wageningen, to this small university, but that has a very global footprint. That's where I'm based, and I lead the Healthy Mothers, Healthy Babies consortium with the support of really able ladies, including Filomena and others in the team. And we also do collaborate a lot with people from your group, Kay, I've seen I think Kay is in the room, Sonia and others. So with that introduction done, allow me to go on to our next slide. Just to quickly give you a reintroduction of the forum. The forum is, and I will come back to really what the forum focuses on, but just to say that it's a platform where experts from all around the world, from different institutions, different geographies, come together and convene around different thematic issues. Specifically, we focus on healthy mothers and healthy babies, and we will spend the rest of this hour talking about that, so will leave that for later. The forum is known very well for the global conference, biennial global conference that it has been organizing for the past decade or so. And I will plug that later towards the end of the presentation, but just you can see the banner at the top there. This year, the conference is going to be in Ghana in September, from the 28th of September. The theme is Nutrition at the Frontiers of a Changing Environment, and we can discuss that during the discussion section. But if you want to know more about the conference, feel free to visit the conference website and register if possible, both annual and hybrid. There's also the Standing Together for Nutrition program, which has been known for really spotlighting global nutrition emerging issues, and has really, I think most people know the forum originally from the work done by the Standing Together for Nutrition program. And then the DINA program, the Micronutrient Data Innovation Alliance, has also been leading the work around nutrition data globally, trying to convene actors from all, large-scale food fortification, how to liaise with governments, what to focus on as far as indicators are concerned. So bringing those people together to speak with one voice. And then we also have the Society for Implementation Science in Nutrition. This is a relatively new program, but also not new because it existed before. It was just given a home within the Micronutrient Forum. And so the forum itself really provides leadership in advancing evidence and policy for not only for maternal nutrition, but for nutrition in general, micronutrient malnutrition specifically, and advances the work with governments, with non-governmental organizations, multilateral organizations, and really creates this global platform where experts can convene also around conferences, regional meetings, webinars, coffee and chai chats. I hope you have managed to join some of our coffee and chai chats in the past. And the idea is to engage and exchange knowledge, but then also shape the agenda around nutrition and then move it forward and deliver it at where it's really needed most at country level. So with that, allow me to use the next couple of 2 or 3 slides just to remind us why global maternal malnutrition is of importance and why we are really focused on it. So we know that globally, many women lack access to nutritious diets. Unfortunately, it's getting worse even as we speak. 170 million women, or 1 in 10 of reproductive age, are underweight. 570 million women, or 1 in 3 of reproductive age, are anemic. And we see a lot of stunting, especially in Southeast Asia, 35% of women being of short stature. And we know this leads to serious risks for women's health, and increases the risk that their child will be born stunted. And then the intergenerational cycle of malnutrition continues. At the same time, globally, these same women do go on to lack access to quality health and nutrition services. So only 38% of women receive 90 plus or more than 90 tablets, or iron and folic acid tablets during their pregnancy. This is what has been given in the past. And as Filomena will really well present, we are advocating for the transition from iron and folic acid to MMS. But just showing that even as we transition, we are coming from really dire statistics. 38% is not where we would have wanted to be. At the same time, only 59% of pregnant women attend 4 antenatal care visits. And as you will know, since 2016, the recommendation is to have at least 8 antenatal care contacts. And so if only 59% are getting 4 contact points in LMICs especially, the situation doesn't look really good. Each year, 20 million babies suffer from low birth weight, and this is an early marker of poor maternal and fetal nutrition. And then what we see now in the last 2-3 years, actually we could go back all the way to COVID period. Conflicts, pandemics, environmental disasters, all these are really making it challenging to access quality diets and health and nutrition services. And this is really leading to not very good scenarios especially for women globally. So poor maternal nutrition really has consequences, not only on the health of and nutrition status of the individual, but also economic consequences. We know that it can affect, for an individual, it's an issue, but then we know that these consequences will span generations. And if you do improve nutrition, then you will also improve other outcomes that have been documented by nutrition researchers, but also other researchers from, education, for instance, improve school performance, productivity, and this at a country level leads to long-term economic benefits for nations. If we invest in nutrition, we could reach at least $5.7 trillion US per year in economic gains to society by 2030. So for us, this is where it starts, because we ask ourselves, okay, the evidence is there. We are aligned on the messaging. We are aligned on what should be done, but is it being done? And this is where a Gates Foundation accelerator event, I think back in 2018, this was still the discussion. This was still the messages. The statistics were clear. And it was agreed that I think there is need, they thought there was need for a consortium that tries to bring together nutrition actors to speak with one voice, to pull in one direction. And so the HMHB was formed then, and was the Micronutrient Forum agreed to host the consortium. And this was with recognition of the fact that maternal nutrition has been ignored as part of the broader maternal health and antenatal care agenda. And this has led to severe consequences for nutrition indicators, pregnancy outcomes such as low birth weight, stillbirth, etc. We know that statistics for anemia, for example, in pregnancy are not so good. In fact, in some geographies, they increase rather than decrease. So there was need for a real action. So HMHB is dedicated to improving maternal nutrition through research, advocacy, and technical assistance. And at this point, I would like to really spotlight our funders, because this would not be possible without them. We are funded largely by Gates Foundation, and now I'm talking about HMHB, not the entire forum. The entire forum has other funders also, but the HMHB is specifically funded by Gates Foundation, Crack Humanitarian, Children's Investment Fund Foundation, Eleanor Cook Foundation, Vitamin Angels, World Vision, and also other actors. We do collaborate, for example, for conference, symposia, but small bilateral engagements. Our mission and vision is therefore to improve maternal nutrition through the collective action of the consortium members. I will, in the next slide, talk about the consortium members. And the idea is to accelerate the availability and effective use of evidence-based nutrition interventions, specifically MMS and BEP. Today, we'll focus a lot on MMS. We'll talk a bit about BEP, but it will be mainly about MMS in lower middle-income countries. We really want to ensure that women everywhere have access to critical nutrition interventions and antenatal care that can safeguard their health through pregnancy and the postpartum period, so the first half of the first 1,000 days. And we also want to be sure that their babies are born with a healthy start in life. For a long time, mothers have been ignored. We focus a lot on the babies, but actually what happens is that the mother sort of is expected to deliver very healthy babies successively. And in some countries, women go on to have 6, 7, 8, 9 babies, keep coming to the ANC, but we never really ask her, how is she doing? We only ask her, is her baby of correct weight? Is her baby looking good and healthy and performing in school? But the spotlight on the health of the mother has not been traditionally kept functioning very well. And that's where we really focus on. And assuming, after a lot of work, and you will see part of it spotted by Filomena, when we take MMS, we want to at least reach 75 million pregnant women and their 75 million babies with high quality MMS, with these women adhering to the intervention and complying to what their medics want, at least per year by 2030. So that's our vision, but we cannot do it alone. And after this slide, I will bring in Filomena to walk you through how we are trying to do it with MMS. So usually what we do is from groups like yours, all the publications that you do, but also from other universities around the world, we collect all the evidence around an intervention such as MMS. We try to discuss what does this mean. Perhaps sometimes we have to do extra meta-analysis, extra systematic reviews, publications. We try to curate the questions, the priority questions we are receiving from countries. And then we ask ourselves, does WHO or the normative agencies, have they provided guidance for this? If yes, we just disseminate. If not, we try to translate the questions and the available evidence into guidance that we could share with countries. We do this in continuous collaboration with normative agencies, especially WHO and UNICEF and the World Food Programme, And usually we publish and disseminate the information that we put together. All our publications are open access. They are public good. It's also the agreement with all our funders that it has to be available to the stakeholders all around the world, especially LMICs. So as you can see, we have a very strong technical advisory arm of things. And on the technical advisory side, we have the MMS TAG. Filomena will talk about both the MMS TAG and the BEP TAG. And we also get questions around other issues of late about calcium, about the use of some interventions in the context of various diseases. And so what we would do is really, as a secretariat, work together with the technical advisory teams that we have to then see, okay, what tools can be developed for countries? How can we translate this to advocacy, outputs, and then to communicate them to countries to make action happen? How do we do this? At least through implementers. We do not have a footprint at national level, so we do not have offices in countries. Rather, we work with the implementing agencies all around the world. So, for example, UNICEF is a major partner. On the data front, we have data share agreements with UNICEF. So we are jointly using the NutriDash data to provide data on an annual basis about the status of MMS implementation around the world. And then countries are also sharing countries. By what I mean by countries is ministries of health, nutrition departments. We have direct contacts where every year they do fill our survey and tell us how things are looking like as far as interventions are concerned. So with those many words, I want to hand over to Filomena, who is going now to give you the technical advisory side of things. She's the one really leading that activity with another program manager who is based in the US, who is Mihaela. And so over to you, Filomena.
Thank you so much, Martin. If you go to the next slide, please.
Yeah.
So Martin told you that Healthy Mothers, Healthy Babies hosts two tags, one on MMS, one on BEP. So why do these two interventions? Because of time constraints, as he explained, today we will focus on the background of MMS, recognizing that BEP is an equally important and complementary intervention to MMS. So I don't think I need to remind this audience that different vitamins and minerals are needed in successive stages of fetal development, from implantation and vascularization of the placenta to the fetal neurological development. If we take the example of zinc, which is a cofactor for more than 300 enzymes in our body, we see in this picture that zinc is needed for implantation, vascularization, hormone production, nutrient transfer regulation, morphogenesis, organogenesis, and neurological development. Right? And you find zinc in MMS. You will not find zinc in the most regular supplement that is IFA. Next, please, Martin. As we know, micronutrient deficiencies are very common, affecting 2/3 of women of reproductive age. In low resource settings, the problem is even bigger. And this graph from global analysis show that multiple deficiencies coexist. Pregnant women in low and middle-income countries are particularly vulnerable because of the inadequate diet in one side, but also because of the increased micronutrient needs. And as we know, micronutrient deficiencies have serious consequences for both the mom and the baby. Next, please. And in case you are not familiar with prenatal MMS, this supplement is one of the solutions to address the nutrient gap caused by the inadequate diets and the increased needs or micronutrient needs during pregnancy. So this table here shows us the recommended dietary allowances for non-pregnant and non-lactating women. Then for pregnant women, where we see that pregnancy increases the needs of certain micronutrients by up to 50%. Then the UNIMAP MMS formulation that was created in 1999 to meet those increased needs for 15 micronutrients. And the most commonly used iron and folic acid or IFA formulation that has only 2 micronutrients and is still the standard of care in several countries. So what are the benefits of providing 15 versus 2 micronutrients during pregnancy? These are the two most complete studies that respond to this question. We have a 2017 individual participant data meta-analysis from 17 trials, followed by a Cochrane review published 2 years later, which included 2 more trials and more than 140,000 pregnant women from various low and middle income countries. And this Cochrane review informed the, next please, the 2020 WHO recommendation on MMS, which is the latest recommendation that we have from this organization. Next, please. So the benefits of MMS in comparison to IFA on birth outcomes in the overall group of pregnant women are represented on the left. They are expressed in ranges because they come from various sources. It basically depends in the methods and in the inclusion of different number of studies in the different meta-analysis that I showed in the previous slide. But they all point towards a risk reduction of adverse birth outcomes such as low birth weight, small for gestational age, preterm, very preterm, and stillbirth. Then we have the benefits for anemic women in the middle, and the pregnant adolescent girls on the right. And for both cases, the benefits of receiving MMS, as you can see, are even greater. For example, for pregnant women who are anemic and receiving MMS, they have a 29% reduced risk of infant death in the first 6 months of life when compared to the anemic women receiving IFA. Pregnant women, pregnant adolescent girls also have a 19% reduction on low birth weight if they receive MMS in comparison to IFA. So in other words, the more vulnerable groups are the ones who most benefit from MMS. Next, please. And there are several guidances or global guidance documents that support MMS in several settings. Since 2007, MMS was recommended in emergency situations. Then in 2020, WHO recommended MMS in the context of rigorous research. In the following year, MMS was included in the WHO list of essential medicines. Then UNICEF has several documents recommending MMS, including a guidance from 2021 to prevent malnutrition during pregnancy and breastfeeding. And a few months ago, FIGO, or the International Federation of Obstetrics and Gynecology, launched good practice recommendations on anemia and pregnancy, where MMS is recommended in LMICs and populations with high prevalence of nutritional deficiencies. Next, please. So now I will move to the MMS TAG, a brilliant group that I have the pleasure of leading, and the evidence-based technical support that we provide in support for country action. So the MMS TAG is a group of 18 international experts in nutrition and maternal health, represented here on the right side, whose mission is to interpret emerging evidence on MMS and provide high-fidelity guidance to any stakeholders from governments, NGOs, foundations, multilateral organizations. And we are lucky to have some MMS TAG members present in this call. So the group was set up at the New York Academy of Sciences in 2018, and initially it was focused on identifying and addressing global evidence gaps, but currently we are more focused on addressing the questions from countries implementing MMS. And I will give you some examples in the following slide. So here we have some, not all, just some MMS TAG outputs organized chronologically to address the evolving MMS needs over time. So between 2018 and 2019, in reaction to the 2016 WHO no recommendation for MMS, an MMS task force was formed, and I think we also have Steve Vosti here in the call. So it was formed to reevaluate the evidence on the benefits, on the safety, and the cost effectiveness of replacing MMS by FA. After that, we did a research prioritization exercise using the well-known Shinri methodology to identify the greatest priorities on MMS. Then in the middle, after the update of the Cochrane review in 2018, WHO changed the recommendation to provide MMS in the context of rigorous research. After that, we prepared the application that resulted in the inclusion of MMS in the WHO Essential List of Medicines in 2021. We also participated at a WHO technical consultation dedicated to MMS and conducted several meta-analyses to address evidence gaps from the WHO guideline, which I will explain in the next slides. And on the right side, in the last, still representing that right corner, in the last 3 years, the MMS TAG work was focused on the needs identified by countries implementing MMS. Many questions are being raised by these countries. How do we use the MMS during image treatment? Can MMS be given during breastfeeding? And in response to those questions, the MMS TAG produced several guidances to address those same questions, which were then disseminated through our webinars or coffee and chai chats. Next now. So another way to look at the MMS TAG outputs is global evidence gaps and technical support to countries. At the global level, when WHO recommended MMS in the context of rigorous research, there was a call for implementation research and clinical research with 3 clinical research gaps, which are described here. If we switch from IFA with 60 milligrams of iron to MMS with half of that iron dose, what is the impact on maternal anemia and neonatal mortality? There was also a call for that in future trials, we should be assessing gestational age accurately with ultrasound and assess if the benefits at birth are sustained into childhood. So the MMS TAG thought, there are 19 trials with more than 140,000 women. How can we answer those questions with existing data rather than calling for more trials that will take many years and God knows how much money, much more resources are needed to produce that data. So we're using existing data. Martin, next, please. Using existing data, we did these meta-analyses looking at the effect of iron doses or these different doses of iron of MMS in IFA on maternal and neonatal mortality. Then another meta-analysis looked at the benefits of MMS according to the 3 different types of gestational age assessment methods, and a systematic review on the effects of MMS on infant growth up to 24 months of age. And the results are all very encouraging from all these meta-analyses. To give an example of the iron dose analysis and the effect on maternal anemia, the question that was being raised was, if MMS provides less iron than IFA, is MMS less effective in preventing maternal anemia? So the MMS TAG looked at all the trials included in the Cochrane review, extracted data on the 3rd trimester maternal anemia and hemoglobin and iron deficiency anemia. We divided the analysis by iron dose in each supplement. So you have here, the groups of MMS with 60, IFA with 60, MMS with 30 milligrams of iron, and IFA with 30. And then finally, the subgroup on the bottom is MMS with 30 and IFA with 60 milligrams of iron. In this last comparison, the effect on maternal anemia was null, as you can see. So, and included trials had really high baseline anemia levels from 29 to 47%. So this shows that there are comparable effects of MMS with 30 milligrams of iron in comparison with IFA with 60 milligrams of iron on the 3rd trimester maternal anemia, even in settings with high baseline levels of anemia. Next, please. And just another example for the question on whether the benefits at birth are sustained into childhood. We conducted a large meta-analysis of 19 trials with assessments of anthropometric outcomes up to 2 years of age. And the results showed that in comparison to IFA, infants whose mothers received MMS had a greater length and weight from 0 to 6 months, a greater head circumference from 0 to 12 months. We also found that MMS reduced stunting, underweight, wasting, small head circumference between 9 to 13% at birth, with even greater reductions around 3 months, but not thereafter. And this shows that MMS not only improves the birth outcomes, but also reduces the incidence of infant undernutrition in a sensitive period of physical and cognitive development. And then we created a publication, just if you don't mind on the next on the previous slide, I'm sorry. I just want to show that we created a publication brief that summarizes the 300 pages of appendices of the paper that was shared as a pre-read in this seminar. So we translated that complex information into a 2-page document that policymakers can understand, and then we translated it to different languages. And I think this speaks very clearly to what Martin was saying since the beginning, from evidence to knowledge dissemination at different levels. Next, please. WHO also called for implementation research designed to optimize MMS introduction, which includes evaluation of acceptability, feasibility, sustainability, equity, and cost effectiveness of MMS. But countries were asking, what does that mean? So the MMS TAG created guidances on MMS implementation research, which were disseminated in webinars. And more recently, we also summarized the evidence on acceptability of MMS in a narrative review. Next, please. And as I mentioned before, the MMS TAG also provides support to countries. In this slide, we have examples of questions from countries, from funders, from Healthy Mothers, Healthy Babies Consortium members. We have questions on what are the benefits of and safety of using MMS in other life stages beyond pregnancy, like adolescent, preconception, breastfeeding. So to answer that, we did 3 literature reviews and produced guidances or technical briefs that summarizes the evidence. Or the second question, how do we use MMS during IMI treatment in pregnant women? Then the MMS TAG created this 10-page guidance with expert opinion from the group on how MMS should be used during IMI treatment. What is the impact of the timing of initiation and adherence on MMS? For this, we did an IPD meta-analysis showing that higher adherence and early initiation results in greater benefits. There are so many recent questions that we received. Can MMS be used in certain health conditions, such as sickle cell disease, malaria, HIV, thalassemias, tuberculosis? These are, they also ask if there are clinically relevant interactions between MMS and medications, for example, antiretrovirals used in HIV treatment. The MMS TAG is currently doing a narrative review with experts in these conditions to come up with practical recommendations on the topic. And finally, how do we pair MMS with other nutrition interventions such as calcium or BEP? And here we will also be developing guidance for these topics. Now I want to bring you a summary of the work done by the BEP TAG, which is led by my colleague, Dr. Mihaela Kissel, who is also present in this call. In case you are not aware, BEP stands for Balanced Energy and Protein Dietary Supplementation and is recommended by WHO for pregnant women in undernourished populations. Next, please. So here you have the list of the BEP TAG members, advisors, and observers. This group was set up in 2024. It's much more recent, of course, than the MMS TAG. And it aimed at supporting and complementing the work done by the WHO BEP expert group. And there are 3 main projects, if you don't mind, Martin, on next slide. There are 3 main projects that this group is currently carrying on. One is a scoping review on the effectiveness, acceptability, and feasibility of delivering mechanisms for BEP, which will inform future programming. The second piece of work are BEP case studies from 9 countries to document the experiences, the opportunities, the challenges related to implementing BEP. And the other is a BEP network meta-analysis to compare the effect of different forms of BEP against no BEP. And these projects are done in collaboration with WHO, WFP, and UNICEF regional officers. Next, please. A number of important webinars and symposiums at scientific conferences on BEP have been hosted, as exemplified here, and these were done to disseminate the most recent findings on BEP trials and other research. And next, please. Finally, we have some BEP communication outputs, such as fact sheets, frequently asked questions, and infographics on the different forms of BEP, which are much needed for the non-scientific audience. And now we will hand over to Martin to talk about the Healthy Mothers, Healthy Babies knowledge exchange in support of country action. Thank you, Martin.
Thanks, Filomena. So you can imagine that even with the nutrition community, the researchers themselves, when you start talking about BEP, you get lost in the detail. Now, how to bring that to the attention of national officers, country and nutrition program managers, and then connect it all the way from evidence to actual products, while at the same time clearly stating that you have no interest in or you're not a shareholder of whichever product carries the intervention that you're trying to bring to them. That has been a very complicated journey. So the next couple of slides before we close, we are going to focus now on this other side of HMHB work. And I have to spotlight that this work is led ably by Rijuta Pandav, who is our advocacy and communications lead, and who really helps us and every day tries to get us to convert hardcore nutrition science into a language that actually stakeholders can understand. You know, the objectives of this arm of our work is really fourfold. One, it's to align stakeholders around a shared agenda, especially around MMS and BEP, but we start to see now other interventions are also coming to the fore. What strategy can be used to advocate for financing, supply, and uptake at national level? What strategy can be used to advocate for domestic financing of these interventions, but also how to monitor their rollout at antenatal care level? How can we raise awareness and build consensus around these interventions, both from the global, regional, and national levels, but also speak as one voice when we bring in the normative agencies, WHO, UNICEF, the African Union, the Asia Nutrition Community? How do we speak with one voice so that we can support adequate policy formulation at national level, regulatory frameworks, but also manufacturing of high quality products that can be delivered to pregnant women or simply women of reproductive age? And then to do that, we would need to convene technical dialogues in conferences, webinars, etc., to address the emerging challenges that, you know, constantly are available, that exist within the world of nutrition, but also because of the changing nutrition funding environment, we constantly have to reevaluate our position and see what can we do given the limited resources. And then whatever is possible to disseminate, we disseminate as either evidence or guidance. And the other pillar is really keep this knowledge available, curated in such a way that national actors know that when they go to the HMHB website, when they go to the Knowledge Hub or the Advocacy Resources Center on our website, the information there is curated for correctness, but also relevance. And they can download, use, sometimes it's even PowerPoint presentations, but it can also be whatever they request. We basically make it available. So that's what I'm going to spotlight. It is not exhaustive, the next couple of slides, so I'll just take thematically. So for instance, when it comes to regional convenings around maternal nutrition, we have had very successful meetings in Jakarta, Indonesia in 2022, in Addis Ababa in 2023. That was in collaboration with the African Union. That was the first time that we were having an Africa agenda to discuss maternal multiple micronutrient supplementation, and countries gathered, they made commitments. And then in 2024, we met again now in Nairobi, and a lot of them had made a lot of strides. And these meetings usually end up with certain agreements. So sometimes they will make a request to funders or request to implementers or request to the research community or request to normative agencies. And we would then curate that because it's their voice, which they work on during the meetings, and publish that in either position papers, white papers, or sometimes it's just conference proceedings or conference reports. And so, as you can see here, for instance, this was on the top right was the document that Filomena was presenting, the implementation science guidance. This was, it looks simple, the people standing there holding the guidance, but the background of that is prior to that meeting, all agencies, I'm talking about the leading nutrition implementation agencies, all of them had their manuals about how to do implementation science. And all of them said WHO has called for rollout of MMS in the context of rigorous research. And our manual is the best. And so governments would write to us and ask, so whose manual is best? Should I go for implementer A or B or C or D? And our job was to get all of them and work together for over 1 year, supported by the MMS TAG, to actually harmonize all their guidances and produce one guidance so that governments are referring to one source of information. And that has been hugely helpful. And we produced the guidance itself and also answered the major questions that are being asked by the senior decision makers in ministries of health. And that now sort of starts demystifying nutrition to ministers, permanent secretaries of health. They start to see a connection between MMS and how MMS is going to actually catapult the economy of the country to the next level. That way, they can recommend it for domestic financing. And then the philanthropists can now be able to see a clear pathway from we are supporting MMS for maybe 5 years, and then we have a clear entry and exit strategy as governments start to take it up. And that's how the conversation starts to build. So Filomena talked about these tailored engagements. I will not go back to discussing them, just showing how they usually happen. Usually we would receive the questions. Ministries of Health would ask us for a technical presentation. What you're seeing on the right, for instance, is when Indonesia, the Ministry of Health in Indonesia was keenly interested in this, having technical questions answered from a scientific level and by an external stakeholder. And following these meetings, Indonesia made the national decisions to transition from iron and folic acid to multiple micronutrient supplementation. Now, if you work back that's a country of over 200 million people, then if you work back to how many pregnant women they have per year, I mean, you can see how the impact starts to show. And you can see at the bottom of the two images at the bottom was a recent meeting where we were now taking nutrition science in a gynecology conference. And for Filomena and I, it was quite an eye-opener to see how we are all health actors, but we really speak in silos. And there are very few of us who are trying to connect the two groups. But luckily, FIGO is a success story where they have managed to listen to nutrition experts and have onboarded MMS very well in their guidances, which means now that national FIGO chapters can then take it up and then recommend it to their governments. Now, this is a unique thing. Although we are nutrition experts, at national level, we have realized as HMHB that once you move out of the nutrition department, the policymakers are actually, most of the times, obs and gyn people. They're from the maternal health group. And if they're not convinced, the nutrition group at the national level has a really hard time. So for us, it's another pathway towards advocacy for nutrition by getting the other group to buy in so that the conversation at the national level becomes easier. So also our work becomes also easier. So just trying to spotlight how it works. And before we come to a close, the other thing that we realized, and also this was our feedback that came strongly from our founders, is the neglect of the Francophone countries. Now, I will not go into detail, just to say that through support from some of our funders, we have now managed to not only engage staff members who are focused on Francophone countries, They are translating all the tools available in English to French, making it available in a language that these countries understand, and also helping the conversation also reach that population. And this has been hugely helpful in terms of achieving the statistics that we are looking for. So it's not easy, but as we mentioned, it's through collaborations with you. I think our most successful collaboration is with UNICEF, where we have an agreement on data, and annually we are populating the world map of MMS activities through an annual survey that we send out, and then together with UNICEF we work so that there is data that is shown through NutriDash, and there is data that is shown through the HMHB world map of MMS activities. And then the other dashboard that countries can then look at is that dashboard of MMS supply. So sometimes it's actually about telling the story from the voice of the women who are actually affected. So this is my second last slide. And I just wanted to show how in these meetings, when we meet, we actually play actual videos of women who have been followed by film crews that we commissioned. And for example, this one from Ethiopia, Agurash, you can read her conversation or an extract from her film. But basically, for me, what catches my attention is the fact that when food is served, she's happy that her family eats. And if she's hungry, she just keeps it to herself because she runs the house. And then, this keeps repeating itself in successive pregnancies. And so MMS is just one of the few ways we could support her. Unfortunately, for balanced energy protein supplementation, we find that the appetite from funders is really not where it should be. And I think it's a difficult intervention to explain what it is. But the one thing that is clear is that undernourished, malnourished pregnant women the numbers are still staggering, and something needs to be done to help them. I'm happy that researchers like Kay have spent a lot of their life working on SQLMS and others. And I hope that we really can make these products available to these undernourished pregnant women. So the success path is really a lot of questions, trying to reinvent yourself. But for us, we hope that by pulling together, we can be able to connect evidence to policy to action. With that, we want to thank you for giving us the opportunity to talk to you today. I know that time is probably gone, but if there is a burning questions and if Sonia allows us, we are happy to answer. Thank you very much.
Thank you so much, Martin. This is a really good overview of all your activities. I much appreciate it. I know it's 10 o'clock in Europe, and I'm impressed how awake you both still are. We have a few minutes, if that's okay with you. If somebody has burning questions, anybody here in the room or online? Maybe. Oh yeah, go ahead.
Oh, hi. I don't have a question actually. I just want to say thank you for such a great presentation that really lays out the whole timeline and the journey. And I think, for all of us, and especially for the students, I think it's really valuable to put all of that together and look at all of the evidence, but then this translation to practice and see how that's happening. So to appreciate the great presentation.
Yeah, the one burning question I have, I'm sorry to take a couple of minutes, but it always strikes me when I'm in a country that it's really the logistics that's a big challenge, right? It's not even, we know iron folic acid works, we know MMS works, but they're not necessarily at the health centers. And so your focus is very much on knowledge and translating that to be available in country. But how much do you get involved with logistical issues that the supplements just don't make it to the health centers? How much of that is the country level responsibility, or probably implementation organizations as well?
That's a really good question. So we support or work in concert with partners who are working on logistical issues at national level. For MMS, for instance, the drug stockouts, which are really everywhere, almost every country you go to, the stockouts are because of multiple reasons, as you know, whether it's because of an exit of an external funder or simply because the national government has not yet procured, or there are very many reasons for the stockouts. For MMS, the costing of the roadmap, the costing of the MMS supply is really where we are playing a role. So we are working closely with Results for Development, trying to give webinars to countries, to nutrition departments, so that they can really cost what it takes to not only procure from UNICEF Supply Division, but deliver that bottle of MMS to the pregnant woman in the farthest corner of the country. If they get the price right, then they can get the funding from either their treasury, the Ministry of Health, Ministry of Finance, or from their funder, whoever is supporting their antenatal care program. They are able to ask for the right support. And then they can be able to make it available over time and to the last mile. We realize that this is really difficult. So tools have been developed that now, these are Excel-based tools that a national actor now has just to plug in national statistics, and then they can, work with the tool to actually get close to the right price point, evidence-based price point. Other than that, I think the other thing that we really do is to advocate with stakeholders that when you fund, you really fund also the cost of delivering to the last mile. UNICEF is a very good example. The UNICEF MMS Acceleration Plan, I think the cost point is almost $20 per pregnant woman. Now, most people will ask, does MMS cost that much? Really, it's not only the MMS. The MMS probably costs $2.50 to $3. But the rest of their money is all the logistics to make sure that it's available so that your concern then is addressed. It's really not easy, I agree, but it calls for all of us pulling together to make it happen.
Yeah, this is really helpful. And thanks so much for sharing these insights with us. Again, thank you so much for taking the time and for being with us this late at night. We'll give you your night back now. Thank you so much. Bye.
I think Stephen Foster has his hand up. I hope, I'm happy to take the question. But
we also have to hand over the room to another group. Oh, Steve has a hand. I see that, Steve. Go ahead.
It's a small hand. I have a bigger one here, but thank you guys. It's good to see you again and hear about all that you're up to. My interpretation of this is it is you guys are primarily working on a supply side. You're working on logistics and you're getting all the ducks lined up so the pills are available when the pregnant women show up, usually in the clinics, which is the major platform from delivery. My intuition tells me that that's half of the battle. The other half of the battle is demand, in the sense that the pregnant women have to choose to go to the clinics early on for every pregnancy. They have to choose to come back and get some of these pills if they need it. And this requires not only decisions of the pregnant women, but their households and other folks in their households. And it becomes even more challenging if you, as you have in the new bottle of pills, it kind of expanded the expected benefit range to include breastfeeding. And so you have to have people who actually believe this and are willing to at least walk to the clinic to get these things, or in some cases to have to actually pay some sort of non-zero price for them. So my question is, how much attention are you paying to these demand side issues alongside all the work that you're doing on the supply side?
That's a really, really loaded question, Stephen. I don't know if Filomena wants to attempt.
I think you'll be better placed to reply, Martin, given your helicopter view. I can only mention that we do not really advocate for MMS to be used during breastfeeding. You know, the guidance that was produced by the MMS TAG was very clear that the evidence is not so strong during breastfeeding. What we say is that if there are remaining pills at the end of the pregnancy, then women can take it so it doesn't go to waste. We have likely benefits and it's safe. So we are not
in the interest of, sorry.
Go ahead. But I think
now that is in the interest of time, and because Sonia has to give the room to the next group, I would say that there is actually a convening happening in the US in April, where the issue of demand creation, but also how to monitor adherence to the intervention is going to be discussed. I think it's led by the Hopkins group, and it's a really, we really have to pull all experts together to try and unpack it, because you are right. Women rarely, as I also showed in the presentation, they only make 4 out of the 8 recommended contact points. Mm-hmm. So even if you give them the intervention, when you get them at the 4th, you know, if they're only 4 visits, yeah, you know, we would have hoped to get them in the first trimester as soon as they know they're pregnant. That never happens. What can we do? We need all the experts in the room to help us see how to make it work. Now, thank you we can, of course, discuss, and hopefully maybe you are invited to that convening in Hopkins, and I'm sure we will get somewhere at the end of the day. But it's always
happy to engage with you on that important issue.
Yes, thank you.
Thank you, everybody. This has been a great session. Thank you so much.
Thank you.
Thank you.
Até logo, Filomena.
É tão bom vê-lo.
Ótimo te ver.